So I grew up in the inner city in Washington, D.C., and I remember always being a very serious child, and a child that was very focused on nurturing others. I was the oldest of three children, and I remember being very attentive to my brother and my sister, and to my dolls, you know, sort of this nurturing nature was there from very young. But the other flip side of that was a seriousness that I had. I used to walk to the local library and bring home a dozen books every week, and, you know, spent a lot of time reading and thinking and observing life. And I think that that might have been partially influenced by my grandmother, my maternal grandmother, who was displaced from Europe and emphasized to us that an education was really key to survival, that it was transportable, that we needed to have some sort of skill set and an education. And so that was sort of there in the background of my thoughts. But I think that I was naturally prone to sort of adopt that message because of my, you know, sort of serious, pensive side. You know, it's an interesting relationship that I had with my grandmother because I'm half Brazilian, and she's actually lived in São Paulo, Brazil. And I could only travel to see her, but every so often because we had limited funds. But she was extremely influential in my life. I learned to speak Portuguese when I was 3 because she said, if you're going to have a relationship with me, you need to speak Portuguese. And we lived in Brazil for 6 months during that period of time, and I've retained the language, even though I don't use it regularly. And I think it was because of this bond that I felt with her. She was very engaged in life and very interested in living life according to her values and living life with all her essence. And I think that that was transmitted to me, sort of living an examined life, as the saying goes. Bioethics, in a sense, especially doing clinical ethics, where you're trying to relate to the whole person, sort of in a holistic sense, really, and you're trying to incorporate the life values of that patient and bring that to bear onto the medical decision-making that's made, is a form of combining science and humanities, if you will. And that's one of the things that really did attract me to bioethics. Two areas of non-academic pursuits that I think influenced me. One was I used to babysit, and I started babysitting when I was about 10. And I worked for a family that where the husband became very ill with multiple sclerosis as a young man. And I watched his wife care for him as he went from a brilliant physicist to an invalid. And she did that at home. And I was very subliminally, I think, affected by seeing her give him a dignified and good death, if you will. And seeing her courage in the face of that devastating illness. And I think that that affected my desire to go into medicine, because I made the decision to become a physician very early on. Then when I was in high school, I worked with a young woman who had dysautonomia which is an inherited rare disease, and she eventually died from it. And she had 2 other siblings who had perished from the same disease. And so she was a shut-in. And I would go hang out with her every week. We'd sit and play board games. We would talk. We would talk about, she would ask me questions on what it's like to be out in the real world, so to speak.
Was this an organized?
It was through a social service agency. So I was one of the volunteers. So I trained at Boston City Hospital, which was a fantastic place to train, with some incredibly dedicated, devoted staff, physicians and residents and nurses. And yet I felt that some of the ethical issues that arose in patient care, particularly with end of life, were not really explicitly discussed. And I remember to this day the name of the patient that I had who was had severe neurologic deficits after being in a diabetic coma, who was assigned to me when I was one of the residents, and actually one of the interns. And every morning I would have to go in and draw her blood to make sure that her diabetes was under control. And she would resist that, and she would pull away. She wasn't able to communicate verbally anymore. She wasn't really able to have facial, eye contact. But she was able to resist that form of pain. And I felt like on some level she was telling me this is not what she wanted. And she would pull out her IVs, pull out her NG tube if she was left unrestrained. And so she was tied down in bed and eventually had a massive heart attack and died. But her sugar was under control, when she died. And that sort of haunted me, if you will, situations like that. So after I finished residency and I was working as an internist, I started to think about the ethical issues that I felt I hadn't really addressed in medical school and residency that I wanted to explore further. And we were located in Florida at the time, in Tampa, Florida, where my husband was in solo private practice. And I started to think about, well, how am I going to accomplish this goal? And the University of South Florida School of Medicine had a department of bioethics, of medical ethics and humanities. So I approached them about establishing a fellowship program in bioethics. And it was a great situation because there was a municipal hospital that had, in addition to its wards, it had an intensive care unit, a medical intensive care unit, a surgical intensive care unit. There was a burn unit, pediatric intensive care, neonatal intensive care, and there was a cancer facility and a VA, all associated with that hospital. So I became the first. After a time, they organized the funding, and I became the first clinical fellow in ethics at the University of South Florida and did clinical consultations in bioethics. It was a situation where anyone involved with the patient, including the patient or the patient's family, or the nursing staff, or the social workers, or the chaplains, or the physicians, could invite me to essentially provide ethics input on dilemmas that were associated with their clinical care. So, right to refuse medical care. If a patient said, I don't want to have this or that done, how would the physicians respond, especially if it might have been a curative intervention? Or how do you understand do not resuscitate in the context of a severely ill individual who at that point in time has no cardiac or respiratory issues? What does that mean for supportive care? Or can a patient refuse hydration? I mean, at the time that I started in bioethics, that was one of the issues. Can a patient refuse hydration and nutrition if delivered through artificial means? What does it mean to allow a child to die? Can we do that with the baby doe laws? And so there were just a whole series of issues that arose in clinical care that I would help everyone address. And it was done in a very collaborative sort of fashion. I wasn't coming in and making a pronouncement. It was done by, talking to the patient if possible, or family members if available, and understanding the patient's life values and what he or she would have wanted in these circumstances, trying to sort of piece that together if the family had not had that conversation. Understanding the person's religious values, if that was applicable and important, and also understanding the medical circumstances, understanding what the team of physicians and nurses thought was appropriate, what the social context was for that person, what the supports were that were available to them, and sort of really digging down deep to see what was really motivating certain decisions. I think about ethics as sort of an organized and objective, as much as possible, analytical approach to moral decision making. And so I could help structure the conversation, I think. I could also help alleviate certain worries that folks might have in terms of what does the law say, what does state law allow or disallow, what does hospital policy say in this regard, and all of that is important. But I think also introducing the patient's values and helping everyone communicate in an unheated sort of problem-solving, consensus-building manner was part of what I did. After doing my careful research, if you will, I would come to a sense of what I thought might be the best approach. But I either was adept at consensus building or fortunate in terms of the ethical situations that I was asked to be involved in. But I felt that we were able, in every circumstance that I participated in, to work through the dilemmas, the concerns, the issues, to a point that of mutual acceptability. Maybe it wasn't 100% the way one person might want it, or 100% the way another. But we reached a place of mutual comfort. So at the time that I was thinking about how I wanted to explore medical ethics, the person that I worked under, the director of the Department of Medical Ethics and Humanities, had done his fellowship in bioethics at the University of Chicago, which had a very well-established program in medical ethics. And so I spent a month there, and I tried to simulate what the University of Chicago had to some extent as possible at the University of South Florida. And I also was aware of the ethics education at the Kennedy Institute of Ethics at Georgetown University, and I came and did an intensive course there and started to think about how I might want to look at bioethics from the theoretical side, not only from the clinical side. And knew it wasn't really feasible for me to do a graduate degree long distance. So I essentially went shopping at the University of South Florida to the religious studies department and to the philosophy department to see whether either of their programs could accommodate my interests in comparative religious ethics and religion and public policy. And the religious studies department was a very flexible, innovative department that had some faculty that was doing religious ethics post Auschwitz and Hiroshima, and he was the director of the department at the time, and he agreed to be my faculty advisor. And and I also had a graduate thesis advisor who was a social scientist and did a lot of religion and sociology. So I took the core requirements for the religious studies department, but also was able to do independent study. And for example, I did an independent study project with one of the faculty members at Georgetown University. And there was another faculty member in the at University of South Florida who looked at medical ethics and humanities. And so I did a lot of independent research on feminism and bioethics. My major focus of interest was comparative religious ethics, and sort of where values or religious values and fit into the public sector in public policy. But I had courses on narrative ethics and what we learned of interest to you from stories, and what are the stories that inform our thinking. My father was a pharmacologist, and so I knew about research from really early on. He would occasionally take us to his lab, and he'd mix a few chemicals together and make the color of the liquid in the beaker change color, and he did he did studies on mice, so I would see the mice and that kind of thing. So I was definitely aware of research, and on some subliminal level, the importance of it from early on. But I wouldn't say that I thought about clinical research until much later, and my interest in it. It's very interesting how I kind of came to the FDA. So when we left Tampa, Florida, and we moved back to the DC area, one of the reasons we did that was because my husband left private practice and went to work at the FDA, and eventually became the deputy director of one of the review divisions in Cedar. And he would tell me how fascinating, his work was, how interesting and how fascinating it was. And so I started to think about the switch from clinical ethics to research ethics, in part based on his input. And very fortunately, I do say that it took an act of Congress for me to be hired at the FDA, and that is actually literally true, because President Bush signed the Best Pharmaceuticals for Children Act in 2002, and that was the carrot, if you will, in encouraging clinical research in children, this notion that children are research orphans, if you will, because 80% of the drugs used in children at that time were never studied in children, and the idea was to protect children from research risks But little did people understand that they would actually be exposed to risks once the drugs were used in them clinically. So there was a very strong desire to encourage more pediatric research, and this was one of the pieces of legislation that did that. But that law required that the FDA hire someone who had an expertise in pediatric ethics. And up until the time that I was hired in 2003, there was no one functioning in the capacity of a bioethicist at the FDA. I was the first. And because I'm board certified in internal medicine, and there was no one else there, I sort of did the spectrum of pediatric and adult issues for a number of years until we expanded the ethics activities at the agency. I found the issues to be very compelling, very, I was very glad to be in that role because I felt that I could be very impactful. I feel like the FDA is very impactful, although it's a frequently, poorly understood agency. I think that it is actually has the capacity for great impact and actually is very impactful. And so that was something that I found very rewarding and also somewhat surprising, not really understanding how much sort of FDA stakeholders, industry, academia, institutional review boards look to the FDA for guidance and help. I also found that there are very caring, committed, thoughtful people trying to do the right thing. I found that when I was, as I said, in my residency and when I was doing my fellowship and at the FDA. Just people were extremely grateful, actually, in all those sectors when you actually help them solve an ethical issue. And so those were a couple of sort of surprises, maybe not the types of surprises you might think of, but I think that the FDA is doing a lot to sort of make itself more transparent to the public. And I think it's also doing a lot, and that's, in many different ways, through information that's posted through its website. But I think, importantly, the FDA also recognizes the impact and the necessity of having input from patients, from prospective subjects, from patient representatives. The advisory committees are constructed to have a consumer representative and a patient representative. But we have offices within FDA that directly communicate with patient representative groups, and we've had meetings to try and bring patients with certain diseases to the FDA to speak about their perspectives on research. One that was recently that I participated in was on HIV cure research. Put it in quotes because it's not really cure research, but it's intended to eradicate the HIV viruses. So how do patients see that research? What risks are they willing to take? What are the endpoints that are important to them? How do they want benefits explained if there are no benefits? I think that the agency is doing a lot now in terms of trying to get that perspective, that, critically important perspective. So that's on a couple of different levels, both in terms of public, and in terms of specific populations. Paul Applebaum and others described this notion of the therapeutic misconception writ small, in a sense, because it was one person's thought that they were receiving, personally designed care as part of a clinical research project. And that's sort of, a rough paraphrasing. It was more elegantly, described in the articles that have been previously published. But I think that we are still grappling with how you communicate about research to individual patients, to individuals. And I think that as we move toward learning healthcare systems and we think about learning from medical care that's delivered, especially through big systems, that whole notion of therapeutic misconception is now going to sort of be writ large, if you will. People will go to hospitals and perhaps not understand how their data or their biospecimens are being used. Or they'll think that information is going to be, the information obtained is going to be funneled back to them directly during that particular, medical interaction. Whereas it may eventually be of benefit to them, but more so to us on a societal level. And so I think that how we communicate about that, how we educate the public, which I think is so critically necessary, and how we develop trust, really, between people and medical institutions, physicians, nurses, the healthcare system, is essential. And I think it's essential particularly now because medicine has come so far away from the Marcus Welby type of situation where you grow up knowing your physician watches you grow up, or you have an extended relationship with that physician and you develop a sense of personal trust that individual has your well-being as the primary directive. And now that we've depersonalized medicine, I think, very unfortunately, that kind of trust is not necessarily integral to the relationship between the healthcare practitioner and the individual. And I purposely don't say healthcare provider, because I think even the use of that term healthcare provider essentially relegates medicine to a consumer paradigm, which I don't think it should be. So how we retain that sort of personal relationship between the system and then the practitioners and the individuals, I think is essential, but it's going to be a challenge. And I think it spills over into research ethics, because I think there will be a blurring of the boundary between research and clinical care. I'm not sure whether it's a matter of asking the right questions per se, except that it's a matter of they should ask themselves, what would I want? What would I want if I were the patient? How would I want this information communicated to me? And how would I want to be treated or cared for? Even broader than treated is really cared for. And I think that trying to sort of see medicine, see the delivery of medicine, of medical care through the eyes of a patient is essential. I think it's critically important, because I think that what will be necessary is honest communication. A lot of people don't naturally know how to do it, and it's certainly not taught well. And I think that medical, I'm focusing on physicians because I am a physician, but this applies, I think, more broadly to healthcare practitioners. But I think that there's just much less time. People have much less time to sit and communicate with their physician. The physician has less time to get to know the person at the other end of the disease. And, and so I think that rapport building, that sort of holistic approach to the patient is unfortunately eroding. And we could talk a long time about that, but I think that as we move forward with changes in healthcare and changes in clinical research, that learning how to communicate about what we do know, what we don't know, what we need to know in simple terms is going to be essential. But as you know, we've talked about informed consent together before. I think informed consent, which is one of the key aspects of research ethics, is still elusive to us. We still don't know how to communicate about a research protocol in a way that people can clearly understand something as simple as randomization, which is like the flip of a coin. 50% of people don't understand that they're being randomized, or how they receive the choice of the study-related intervention. So I think that we have a lot of work to do on sort of public understanding of clinical research. And if we could get the public trust and the public understanding of clinical research, it would be essential and extremely productive. There are a few things that I would say that I'm particularly proud of, and I won't take sole credit for this. I've worked with others, but I've been particularly proud of sort of helping to create internal teaching materials on informed consent for reviewers, so that they can better understand their roles in making informed consent as robust and as informative as possible. I've been very proud of being involved in better understanding pediatric ethics and ethics on the exception from informed consent for the study of emergency research, and moving that forward, issuing detailed guidance on that, and also have been proud of sort of work that I've done on the study of pregnant women in an ethical manner. I think that people at FDA are more consciously thinking of ethics, not to say that they didn't think about it before. I think they more explicitly think about ethics and, seek input as needed. And I think that that's because there's a recognized group of us now who are attending to bioethical issues. When I first came to the agency, I sort of shopped around the fact that I was there and went to the center directors and division directors, and I was advertising, if you will, my services to the agency. And I think that there's just a more fluid sort of approach to bioethics now. Both clinical and research ethics, people or institutions generally think that they can do that and they don't need a bioethicist. I'm an ethical person. I can handle ethical issues. And so there isn't always a clear understanding on the part of, and I say institutions broadly, hospitals, and other entities. And so there may be people who are interested in ethics who sort of volunteer to do it, but without formal training in it. And that's certainly important, and I don't mean to disparage the contribution that those people make. But I think that there's a lot to be said for having a rigorously trained ethicist, whether it's clinical or research. And because there isn't always the recognition of the need for it, although sort of uniformly people, as I said before, are relieved once they have someone help them sort through ethical issues. It's a hard professional market, if you will, in which to find a job. So I would encourage people who are interested in ethics to follow their passion, but also to obtain some sort of a terminal degree associated with the bioethics. And there are a lot of different ways of doing that, through public health, through law, through medicine, through philosophy, through religious studies, anthropology, lots of different ways. But I think it's important to have a certain flexibility in one's, so that there's a, sort of a malleable career path, if you will. I mean, as you can see from my story, I was a pioneer in a few different times of my life. I think that I'm sort of a very cerebral person. I like to sort through problems and complex issues. And I think that that's helpful. I think also being able to be empathic and sort of understand the perspective of the other person is very helpful, because I think that frequently there may not be a right answer. There are, complex issues that are multifaceted, that don't lend themselves easily to one single right answer. And so I think being able to build consensus and working toward a solution is another important sort of attribute. If only I had unlimited resources and authority, I would do that public health campaign that I talked to you about, and sort of educating the public as to the importance of clinical research and safeguards, and so that they would understand what rights they have and how they're protected, but also the critical importance of clinical research. And along with that, I would build into medical schools curriculum courses on clinical research and clinical research ethics, because I think that it's become its own specialty in a sense. And I think that if people felt, if physicians felt more comfortable with clinical research and the importance of it themselves, then, and they felt more facile with it, they would probably engage in it more. And the questions that come to their minds are questions that they could actually try and research and explore. But that goes back to what we talked about before, sort of trust and communication and developing skills.